Welcome to the lecture that continues regarding malignancies in women's health. The next two short lectures are going to be about breast cancer. When you look at the photo here, no one is immune. When you look at this picture of the anatomy of the breast, it gives you a good idea of areas where breast cancer can develop, as well as due to the lymphatics and the vasculature of the breast, why it can become metastatic quite easily. When we have breast cancers, it can affect the ducts as well as the lobules and the breast tissue itself. So signs and symptoms. There actually are very few unless it is in an advanced stage. Some of them are detected by self-breast examination, but most are detected through provider evaluation. When a patient detects one on themselves, it's doing the self-breast examination. Occasionally, they will actually notice something when they look at themselves in the mirror. But this isn't good because it means that this is in a more advanced stage, because what they see is a puckering or a pulling of the skin. And what that indicates is that the mass that's underneath is pulling on the exterior part of the skin. There can be pain involved with breast cancer, but as I said, this is more in the form of an inflammatory breast cancer or advanced disease. So look at the cascade of symptoms that we can see. If we can find it when it's just a lump, the management, treatment, and recovery is much easier. If it's affecting the nipple and it's being pulled, it may mean that it is more advanced. It really depends on where the mass is. So there can be pulling of the nipple as well as dimpling, and those both indicate the same thing. There can be dripping from the nipple. Now, the dripping in and of itself does not mean it's advanced. In fact, ductal carcinoma in situ is probably one of the better cancers to get because it is exactly that, in situ, confined within the duct itself, very treatable. But then there can be more advanced breast cancers that are dripping, but it's not really dripping out the nipple, it's dripping because the tissue has become necrotic. There can be redness or a rash. I've never seen a rash, but I have seen the inflammatory breast cancer. And then the other skin changes. And when we talk skin changes beyond the redness, we're talking about that peau d'orange, and that's P-E-A-U. And so the skin looks like an orange peel. And this is usually indicative of more advanced disease. Now, not to scare you, in regards to lumps, not all of them mean that there are cancer. So read about fibrocystic breast changes and fibroadenomas that can occur in the breast. In fact, many of you are at risk for developing these fibrocystic changes, and then those of you who are really young, the fibroadenomas. And so the picture here with this little yellow mass, that's a fibroadenoma. So it's very rubbery, lobular, and we just resect it. So look in chapter 32. You do need to know the difference between breast cancer, fibrocystic breast changes, and fibroadenomas, what they are, who's at risk. So a little bit about the statistics of breast cancer. It is the most commonly diagnosed cancer in women, and it is the second most common cause of death related to cancer. 35% of the breast cancers are going to occur in our younger age group, so prior to the menopause, which means that about 2/3 of women are postmenopausal. 5% of women are going to present to us with advanced stages of cancer. And the cancers have different qualities. It can be very localized, especially with the DCIS. It can be hormone receptor positive or negative, and this helps develop the treatment protocol. It can present as metastatic disease, or it can be treated and then recur. And it can recur 10, 15 years later. Most cancers are hormone receptor positive to the estrogen or progesterone. So, who's at risk for developing breast cancer? Well, really, any woman as they age, they have age as a risk factor for developing it. If they go through menopause late in life, so instead of going through menopause in the early 50s, we have somebody who is in their late 50s, early 60s. Because of the continuous influence of estrogen on the breast tissue, this is why they have the risk. Now, there is an error in this slide, long-term use of ERT, not ART. And ERT is estrogen replacement therapy. If they've had a personal risk of cancer somewhere else, this increases the risk that they can develop a breast cancer. Family history of breast cancer, especially if they are BRCA1 or BRCA2 positive type cancers, increases the risk of all the females in the family. Patients who have been radiated to the chest or to the breast increases the risk because of the destruction of the tissue itself. Dense breasts can be a risk factor because they are very difficult to actually palpate a lump in there, and it isn't until the lump has gotten to be a significant size that it stands out. So these women will present with more advanced disease. DES exposure, alcohol, which is really tough to quantify how much alcohol do you need to drink to increase your risk. It's really not well defined, but it is a risk factor. And an interesting factor is working during the night shift. Now, is it because of cortisol? I'm not sure, but because they've been doing the nurses' health study for about 4 decades, we're seeing that women who work night shift for a protracted period of time have an increased risk of developing breast cancer. So, can we prevent this by modifying the risk factors? Absolutely. We can control obesity by modifying diet. We can promote exercise in women. Not having a child and not breastfeeding increases the risk. And so, do we want to push women into having children just because of the risk of breast cancer? Not really. But just know that that is a potential. So, what we want to do is promote behaviors that reduce the risk. Don't wait until you're in your 40s to have that first pregnancy. Let's promote breastfeeding. Let's reduce stress. I think the faculty need to be taking that into account, considering that the majority of our students are women. Are we promoting breast cancer? Not really. I like this quote. Career women have 70% higher risk of developing breast cancer than housewives or women in low status jobs. And why is that? Because of the stress factor. I think we're going to learn a lot about the influence of stress taking its toll on our bodies in the long run. So, for the evaluation of breast cancer, we'll start out with a mammogram. So some breast cancers are detected just through that screening mammogram. We didn't feel anything clinically on the exam, but because of our technology, we can find something when it's small. Now, if a patient has come into us and is complaining of a lump, then the physician or the nurse practitioner will order a diagnostic mammogram, not the screening mammogram. The diagnostic mammogram is going to be the standard type as well as magnification views of where the lump has been detected. And this may be followed by an ultrasound. Some of the breast ultrasounds are followed with an immediate fine needle aspiration. If it looks cystic, they can puncture the cyst, withdraw the fluid, and it's over and done with. And so simple cysts have a characteristic discharge. It's kind of greenish, clear fluid. We don't even send that off to pathology. But if it looks unusual, then that fluid will go off to pathology and they're going to capture the cells and look and see if there's any type of malignancy. Some women will be triaged into getting a breast MRI. And then others will end up getting a breast biopsy, and we do a fine needle aspiration of the lymph nodes that are surrounding. We can do the human epidermal growth factor receptor testing, and this, if it becomes positive, then the treatment for this type of a breast cancer is going to be with the biologics. So I want you to look at the picture in the lower right. It's not the greatest because they're fairly small, but the fine needle aspiration is just that. We're using a very fine gauge needle to go into a mass, and they'll make multiple passes, and they're going to be aspirating as they come out, go in, go out, and we send that off to pathology. A core needle biopsy literally takes out a small core. So when you think about the size of the Huber needles when we access a port, it's a little bit bigger than that. And so they're going into the mass and they're just taking out all of that tissue. And then we have the surgical biopsy. Because it may be difficult to palpate, we can see it on mammogram or MRI, but we can't access it in an outpatient setting. So these women will be triaged to the operating room. This ends part 1 of breast cancer.